You can tell when you're
now.
at the IOM, the telephone system is more complex than anywhere else because everyone here is so smart. Lauren, are we cool? Lauren, are we good? Yes. We actually are? Great. Well, as threatened, we're right on time, sort of. So we're going to have a chance now to do the eagerly anticipated social services panel. I'm not going to read the instructions that are on your programs, but again, it's the same as we, sort of getting a sense that we're asking every panel for the same thing, but except within their domain. And so we're very pleased that CDR, which must mean commander, I'm very. You've done this before. That the Cedar Tree, Jonathan White, is with us. He is the Deputy Director of the Office of Human Services for Emergency Preparedness Response, the Administration on Children and Families. And so, Jonathan, let's go ahead and get to your presentation, and thanks for joining us.
Terrific. Thank you all. So I want to jump right in to say that this will be the motorcycle tour through the Louvre. You may see the Mona Lisa passing by you at 75 miles per hour. Whether it's in the little bit of time that we have for questions, or I hope in any other contacts you wanted to make to reach out to us to me or to us in OSEPR, I want to be available to help you look at ways to integrate the public health and medical dimension of recovery to the human services, sometimes called social services dimension. There are many components that together make up the human services or social services systems in the United States that families, individuals, and communities depend upon. I have selected 9 that are sort of types of programmatic activity that I really want to emphasize as having the clearest and most compelling significance for the long-term health outcomes post-disaster of communities. I have no time to go into any of these in depth, but I want to just touch on them, and then you'll hear me talk about them more. So first of all, programs directly related to the economic security of families, means-tested, generally cash benefit programs, of which, of course, the most important, supported by the agency that employs me, the Administration for Children and Families, is temporary assistance for needy families. Although other federally and in some cases state-funded programs might also be viewed as being part of that spectrum. Next, child support, which is again coordinated federally by ACF. And is in fact a really critical program for health outcomes for children in ways that are not always apparent, but I'll talk about in a second. Third, the spectrum of early childhood programs, which is the general banner that we use to talk about Head Start and child care systems. And I'll talk about those in it. With specific attention to the way that Head Start is, of course, a federally funded undertaking, and child care is really unique of all the systems I'm going to talk about in that it is, in fact, a marginally profitable for-profit business, not a nonprofit undertaking in most cases, not a state, local, or federal government undertaking, but our agency in the federal government, ACF, has a significant role in assuring access to child care services for working families. Fourth, family violence prevention and services. So again, this is coordinated federally by ACF, but through the states, through the state domestic violence coalitions, which are NGO networks, and state administrators, which is the lead state official. But the family violence prevention and services, precisely from, we've touched on this some today, the ways that disasters increase the risk of domestic violence. This is really a whole presentation unto itself, but this is the 4th sort of sector I wanted to touch on for this reason. The 5th I've somewhat clunkily put together, but it's useful for this discussion, 3 systems that are overlapping but actually distinct: child welfare, foster care, and in states with systems that work this way, adult protective services. Again, at the federal level, this is funded by the Administration for Children and Families, but this is fundamentally a very, very different undertaking state to state, primarily a province of state decision-making and generally local government execution. 4th or 6th, Nutrition assistance, of which the principal programs in the U.S. are funded by the U.S. Department of Agriculture. The two most important are the Supplemental Nutrition Assistance Program and the Women, Infants, and Children, or WIC program. And of course, SNAP significantly actually has one of the very few federally funded, specifically disaster human services programs, which is DSNAP. Next, energy assistance. Out of ACF, we fund the Low Income Home Energy Assistance Program, or LIHEAP. That is, again, administered as a formula block grant to states, and each state has its own energy assistance program. But this is a means-tested program to help provide the means for heating, cooling, and powering homes to low-income families. Next, aging services, which is a really broad rubric that has several different kinds of programs in it, principally those funded federally by the HHS Administration for Community Living under the Older Americans Act. But there are a number of other kind of aging services, too. And last, a whole spectrum of programs we could maybe characterize collectively as vulnerable populations assistance, which are human services, social services programs that target people who are at particular forms of social and economic risk. That's refugees and asylees, which, for example, was one we do out of ACF. That's runaway and homeless youth. That's also ACF. That's the homeless population broadly for needs other than housing. Because I want to be clear, housing is not strictly speaking a social services or human services issue, but services to the homeless population, including sheltering, may be. Transitioning, foster youth, survivors of human trafficking, et cetera. So I picked on those 9. Here is the easiest way I could think of to show you how these types of programs directly, proximately impact health outcomes at the individual and population level. Now, this lends itself to a really long talk, and I have a really short time. So I will talk about the mechanisms that work. A number of programs directly and proximately lower the risk of serious injury or mortality due to injury in people post-disaster. That includes principally early childhood programs. There's a growing body of evidence. The safest place for a child to be post-disaster, for a significant period of time post-disaster, is schools, Head Start, or child care. Those are often safer than the neighborhood. They're safer than recreation facilities, and they're safer than their homes. That also includes programs like child welfare and family violence that prevent injury and mortality due to injury every day, but have particular sort of post-disaster implications. And includes other programs that lower the risk of injury or mortality due to injury, like aging services and vulnerable population service programs. Next, some human services directly affect your odds of getting access to health care. Now, strictly speaking, health access programs we generally don't talk about as being a human services or social services undertaking. So SCHIP, Medicaid, these are really in a different domain of programs. But we have a number of programs that directly do affect health access, and one of the most important is child support. 20% of the children of the United States get their access to health care, get private insurance through a child support order from a non-custodial parent. 1 in 5. So child support happens to be a pretty resilient and robust system post-disaster, but the effective continued delivery of child support really has profound ramifications for health access for children and the ability of the federal government and the states to afford the health care needs of children who might lose access in some other way. Similarly, child welfare has significant impacts for health access, aging services, and vulnerable population services. Earlier you heard something about toxic stress. A number of emerging studies indicate that while we've had a historical focus often in disaster behavioral health on traumatic exposure, we've probably not paid sufficient attention to the reality that grinding, long-term, chronic, severe stress is a very important predictor of adverse sequelae. And a lot of, when we look at that data, a lot of the stresses are ones that we mitigate or have our best mechanisms for mitigate in effective delivery of human services, particularly the economic security programs and the other programs that reduce sort of some key measures of household stress, right? You can see that in this column. I think there are a number of economic determinants of health that are primary tools for mitigating those economic determinants of adverse health outcomes. To look at sort of the social and economic determinants of better and worse health outcomes, our main tools in this country for mitigating those are social services and human services. So you see the number of these program areas deal with those. Those include specifically things like, for example, nutrition and energy assistance programs. You will definitely tend to have worse outcomes in a disaster if you cannot afford food or if you're making choices as a household between food and medicine. This is exactly the reason that some of these programs exist. in terms of behavioral health sequelae. So this works in a couple of different ways, two different sort of sub-mechanisms. One is, do these programs facilitate linkages to clinical or subclinical services? And I'll talk about this more. Early childhood programs such as Child Care and Head Start play a decisive role in linking children and families to both crisis counseling level and other kinds of resilience promotion at population level, as well as linkage where screening and linkage where appropriate for clinical therapeutic treatments. Okay? And you see that for some of these others as well. Environmental health issues. We've seen a lot of progress, especially in the last couple years, in the strategic use of human services to reduce the level of environmental health risk faced by especially low-income households and households with children. Again, this is something we can talk about in detail, but a great example would be the partnership that ACF and EPA conducted in Sandy recovery in New York and New Jersey to reduce the likelihood that children served in early childhood programs would be exposed to asbestos, lead paint, or black mold. And last, developmental risks. So we're thinking specifically, especially of children and youth, the way that disasters pose very particular developmental health hazards can impede the normal developmental progression. And just as in so many other kinds of non-disaster crises that can affect communities and families, these are precisely the programs that often give us the best tools to address potential hazards to children's healthy development. So again, I apologize for the high speed with which I want to go past this. So in terms of funding pathways, here's a really, I think the bottom line lesson learned is the main way we fund human services in the United States is federal dollars that don't look federal when you get help. Okay? So what's the number one mechanism? It is federal block grants to the states and tribes. By far the biggest mechanism. There are also fed-to-field direct grants. Head Start is the example of this par excellence. Every Head Start center gets its money directly from ACF. Okay? Each Head Start program is funded directly by ACF. The states and the local governments aren't in the Head Start game. There are also grants that can go to states to support direct governmental activities. Child welfare is principally a governmental activity at the state, local, county, tribal level. But it is generally funded with federal dollars, and depending on the states, also in some cases with state tax revenues. But that's an inherently governmental function. Okay? By contrast, when you see something like, for example, family violence, we give money under the FIBSA grant to states that funds both governmental activities and non-governmental activities, because sheltering women and their children from men who wish to do them harm, for example, is essentially a non-governmental community and faith-based enterprise, not a state enterprise. When we combine nutrition assistance and public assistance, those aren't all of the things I've talked about, but that's the biggest chunk of what I've talked about so far. Then in fiscal 13, that was $103.6 billion. That was the biggest slice of the pie for block grant funding to states after Medicaid and CHIP. Okay. Who are the big federal players? HHS ACF, HHS Administration for on Community Living, USDA's Food and Nutrition Service. There are a lot of other players, but those are the biggest ones. There are other social services funding streams that do include state appropriations and nonprofit, mission-raised revenues, and private for-profit business, especially in the case of child care. Child care is a very unprofitable for-profit business. That's one of the backbones of our nation's resilience, and that's why, for reasons I'll talk about some today and more, I hope, in other conversations, child care is always the most at-risk part of the system. So, decision-making pathways. The central role for human services and social services in recovery is the role of state or tribal government, and depending on how the degree to which a state has a home rule process in place for social services decision-making, also the local agencies. I need to say this. State, tribal, and local human services agencies are generally poorly integrated into emergency management world. And one of the challenges when we start building increasingly centralized ICS-based structures for recovery, one of the flip sides is that the level of expertise and integration necessary in these decision-making processes is often not present. So as part of building those capabilities, one of the things you hear me say many times, we need to effectively integrate human services decision-making into public health and medical and emergency management decision-making. At present, that integration in most places federally, state, tribal, and local level is not strong. ACF, part of our role in the federal response world is that we really conduct most of the situational awareness and needs assessment that federal decision-making is based on. Right? We do that in support of FEMA in the response phase for Emergency Support Function 6, and especially in support of HHS ASPR for the National Disaster Recovery Framework Health and Social Services Recovery Support Function. There is significant autonomy of action for decision-making by the non-governmental organizations or social services providers, whether they're working with their own money or ultimately with federally or state-derived funds. They often have a lot of autonomous decision-making. They may or may not be very integrated into the disaster coordination system. When they are, they may be linked through the Health and Social Services Recovery Support Function, or they may be linked through the FEMA Voluntary Agency Liaisons. It's case by case. There is a growing effort to coordinate and consolidate all the decision-making that I'm talking about. The leadership on that really is being brought by the Recovery Support Function, which is administered for Health and Social Services by HHS ASPR's Office of Emergency Management Recovery Division. Within HHS, we are working to finalize a process now to have interagency coordination. We have an HHS Disaster Human Services Concept of Operations plan currently in department-wide clearance. It's been 3 years in the making and 5 years in the thinking about it. So that's decision-making. Big three take-home lessons learned from the field from recent disasters. Number one, significant gaps remain in the interoperability of human services and social services with emergency management and public health at all levels. All levels, local, state, tribal, territorial, federal. Right? The second take-home lesson, childcare has particular challenges in recovery. I don't have the time to go into that, but I'll give you 2 free bulletins. Number one, the mean earnings of a child care provider in the United States is $26,000 a year, and the mean level of education is 10th grade. And 2, the degree of, in most states, even state oversight of child care is very small. 50% of America's child care providers are unlicensed and outside the realm of state regulation, okay? With conditions varying greatly from state to state. Child care are for-profit providers that are often not credit worthy enough to get some kinds of banking or even in some cases SBA furnished loans for reconstruction, but as private nonprofits they are ineligible for FEMA public assistance. They are chronically unable to access the funds they need for rebuilding. Third take-home lesson learned, the client populations that we serve every day in human services and social services map very precisely to the key at-risk populations for adverse health outcomes post-disaster. So for recommendations, 2 recommendations for each of these subphases of recovery. First of all, a promising lesson learned, in fact we did a brief on this at an IOM meeting last summer, is a promising practice that we have helped to develop in ACF, working in partnership with states and with NGOs like Save the Children, is to convene children and youth task forces. This was enormously helpful in Joplin. We expanded it further for Hurricane Isaac in 2012 and in New Jersey and New York for Superstorm Sandy. This is essentially a shared forum led by the lead state agency with Equities in Children and Family Services, but all the state, federal, and NGO players who serve children every day are convened in a shared forum to pool resources, develop a common operating picture, and a shared strategy. That's everyone from individual pediatricians, child life specialists, pediatric psychologists and social workers, to the rec agencies, the child welfare agencies, the child care providers, the Head Start grantees. We've produced a guidelines document. The link is here, and I encourage everyone who's not familiar with it to really get to know it. We see this as an extremely valuable practice. Second, for short-term recovery, it's critical to assess child care impacts and to convene, if needed, a child care recovery group. That's often a useful thing to convene under that Children and Youth Task Force if required. We've identified the sort of key partners here you need to rebuild child care, which is a lead child care and development fund agency in the state, the child care resource and referral agencies. Our agency can support, FEMA can support, Save the Children, but most importantly, bring in the individual providers. So for intermediate recovery, really key recommendations, see this again and again, establish linkages between behavioral health planning and support systems and early childhood programs. We have seen all too often, schools are looped in, child care and Head Start is not. That is a deeply unevidence-based approach because the greater risk is birth to 5, not 5 to 18. right? So if we want to go with where the science says is the critical form for risk, it's imperative to establish strong linkages as well as with the schools, also between behavioral health and Head Start and childcare. Second, we've seen a lot of promising practices. It requires no additional funding or staffing, including in your messaging, to promote awareness of the National Domestic Violence Hotline. The ACF-supported National Domestic Violence Hotline we've seen in a number of disasters, starting really with Deepwater Horizon, is extraordinarily useful for as a force multiplier as often services become overwhelmed within a given community. It can provide 24/7, 365 access to a skilled counselor for people who have concerns about domestic violence, and it also has real-time situational awareness on where help's available in the community. So we strongly encourage that awareness about the hotline be included in emergency congregate shelters, in individual clinician provider offices, and in other places where we might make contact with survivors. For long-term recovery, two sort of key recommendations. It is really valuable that all the partners agree to support effective and coordinated systems of disaster case management, whether it's being done by the federal government, I should say, the office where I work and the agency where Kim works are both involved in the federal disaster case management program in partnership with FEMA. But whether it's the federal government doing it, voluntary organizations active in disaster, the state government, whoever's providing it, it's very important to have well-coordinated and robust disaster case management systems. So that the people most in need of being linked to available services are navigated to them. And second, for long-term recovery, it's very important to leverage your recovery experiences under the NDRF to build greater capacity and interoperability for human services preparedness for future events. There's a short window of opportunity during the recovery period to build relationships between the public health and medical system, the emergency management system, and the different human services systems to leverage going forward. We see a lot of the good things that have happened in more recent disasters in the last couple of years have built on foundations learned in recovery from the previous disaster. But the window is short during the actual sort of operational long-term recovery phase. Because recovery does happen, and this is actually sort of the message I feel I always have to say. It's really critical. Recovery does happen. The social services and human services systems that are working in communities every day really are in the business of seeing recovery happen from micro-level catastrophes, and the basic principles as well as the techniques there are very broadly applicable in disasters too. So I'm always available, and as is my director and our team, we're available to help public health and medical colleagues who are looking to build that interoperability and integration.
Thanks.
I'm sure there'll be questions at the end. Thanks.
Thanks. Thanks, Cedar. Hey, Lauren, could we make sure for tomorrow's discussion that we have two things from this one, the copies of the decision pathways and the recommendations? But I'd like to make sure we also have in front of us the decisions pathway slide. So Kimberly, you're going to help us to see the world through the eyes of someone who is the Senior Director of Disaster Response Operations for Catholic Charities, which means you guys really do kind of deal with real life every day. So we're looking forward to your conversation.
Yes,